I think we need to be leveraging these larger data infrastructures to inform our practice. There's a lot of doulas who may be living in one community but may not be as aware of what's going on in these adjacent counties. I would just encourage you to familiarize yourself.
Welcome to the CCDS Doula Collaboration Podcast, where birth and postpartum professionals come together to learn, grow, and support one another. I'm your host, Melissa Harley, a doula trainer and passionate advocate for the power of birth and postpartum care. This podcast is a space for authentic conversations with doulas and other perinatal professionals, from those just starting out to seasoned experts shaping our field. We'll hear from those in my circles, industry leaders, and community change makers. And I hope that you'll find inspiration, education, connection, and collaboration here. Thanks so much for joining us. Let's get to it. Hi, Rose. Welcome to the podcast.
Thanks for having me, Melissa. It's good to see you.
Great to see you. Tell everybody a little bit about you and what you have been doing.
Well, I am doing quite a few things right now, but I think it all connects to what your audience is also doing, which I'm sure are many things. I am a doctoral student right now at Emory University. My research has focused on reproductive health inequities in African American birthing communities, looking across the life course. I have previous experience doing doctoral work at Florida State University, but before that, I was actually doing doula work and I was a chaplain as well. So that intersection of working in hospitals as a spiritual care provider, as well as working as a birth worker, really sparked my curiosities about reproductive health, the disparities I was seeing personally, and just trying to find some strategies and solutions to addressing this from the way I knew how to do it best, which was through research. So that's what I'm trying to do.
So you were started as working as a chaplain, if I remember, when you took doula training, and then you became a doula, like you mentioned. What led you to want to go back to graduate school and to further your research?
I think it was a mixture of my professional experience and personal experience. So from the professional landscape, I was working as a chaplain who would be called to labor and delivery sometimes, but never for the happy cases, right? Not for baptisms or anything like that, but really for those moments where either baby's life was threatened or mom's or the birthing person's life was threatened. And so I actually witnessed mothers go into cardiac arrest while I was working there. I can actually recall the night I knew I wanted to do research. It was the night we had 3 back-to-back calls in labor and delivery, and I was called to respond to all three. All 3 of them were cases of cardiac arrest, what we would call a code blue. And as I was supporting those families, I noticed that each family was a family of color. Luckily, 2 of the mothers survived. 1 of the mothers did not. And that was a pivotal moment for me where I realized these disparities are not only impacting, people in my community as well as myself, which I'll talk about in a minute, but people who are just expecting to have the best day of their lives and walk away broken, trying to piece together a family that's missing a crucial person. So that changed what I wanted to do career-wise, and I became interested in becoming a doula. I actually did my training with you, Melissa, a few months after that experience, and I realized that doula work was very important, but I'm also a researcher at heart. So I wanted to go back and see if I could get some of these stories on paper to really address what I was seeing in the hospital. The personal experience that I had that really attracted me to doula work as well as my work as a researcher was with my first child. I have 2 children. I have a daughter who's 8 and a son who is 5. And when I was pregnant the first time with my daughter, the doctors actually told my husband and I that our daughter would not live past her first birthday, that she would have problems throughout that very short life. And of course, that news was devastating for us. As a spiritual person, I did a lot of praying and I did a lot of hoping against all odds. And she's 8 years old today. She's healthy. But that kind of shifted. That was my first aha moment. There's something going on in communities that I hadn't had an opportunity to talk to talk about with my mother or my aunts or anything. And I'm wondering, how often does this happen? Are people walking these very unexpected and unknown pathways by themselves without support? So that was an awakening moment. When I had my daughter, everything went well. She was born healthy, as I said, but a few days later, I actually ended up having to go back to the hospital for postpartum eclampsia. I did not even know what postpartum eclampsia was at the time, but that experience again awakened me to the lack of awareness around these issues that was not only detrimental but life-threatening, and sometimes actually takes away people before they, preventable deaths before they need to be taken. So yes, between my personal life and my professional life as a chaplain, I became heavily invested in reproductive justice and the work that I try to do today.
Well, first of all, what a miracle from your daughter's standpoint, and just having her here at 8 years old. I know that must have been a really challenging experience all in all. So what an absolute miracle. Let's hold space for that for a moment. It's so impactful, I think, that we see headlines a lot, right, about the disparity in maternal mortality with people of color. We see the numbers 3 to 5 times higher than, their white counterparts. We hear the conversation about it. But when we start putting faces, real faces to it, I think that's when we really start to understand that this isn't just a number. It's not just a stat. There's very real lives that are being affected and people that we care about in our communities. So thank you for sharing that journey, because I think that's so important. So tell us a little bit about what degree you started to pursue academically, and kind of how that led into the work that you did with your paper that you wrote.
Yeah, so when I was a doctoral student at Florida State, I was studying sociology, and my particular track or concentration was health and aging, specifically reproductive health across the life course. That was my initial work, but right now my doctoral training is primarily focused in Black studies. So I can really get a better understanding of not only how are we seeing those numbers play out today, but what are the historical trajectories that are like underpinning these contemporary experiences of reproductive health inequities. So I think those two disciplines complement each other really well for the work I'm trying to do.
I love sociology so much. When I went back to finish my degree recently in the last couple of years, I did a concentration in sociology, and I was like,
Oh,
where's this been all my
cool.
life? I love this so much.
I know, that makes sense.
Really, it's just, this is my layman's term way of sharing about it, but just understanding the ways in which groups of people move and work and live, and how cultures evolve together, and all the influences that come into play with all of that.
Mm-hmm.
Yeah, I love sociology. I think it's not lifted up enough, I guess, as an important part of
Mm-hmm.
academia. I love it.
I agree. I was a latecomer to sociology, and I only stumbled upon it because of the stuff I was reading as a doula. Like some of the books were written by sociologists. So I was like, oh, so that made sense. So I'm glad I did it. Mm-hmm.
Absolutely. So, okay, where are you in your studies before we dive into your research? But where are you in your studies now?
I am technically a first year doctoral student at Emory, even though this is really my fourth year doing doctoral studies. So I have a bit of ways to go. I'm in coursework, and I'm also doing research simultaneously, which is a heavy lift, but a lot of fun. A lot of fun.
Okay, so let's dive into your paper that was published. And was it Sociology Today?
Sociology of Health and Illness.
Okay, yeah. So share a little bit about, well, let's start with, if you want to share the title of it and just a little bit of background, and then we can dive into it more.
Sure. So the title of the paper was Surviving in the Midst of Quote Unquote Nowhere. I'm looking at it. It's Disrupting the Conceptualization of a Maternity Care Desert. And so that paper, again, really emerged from my doula work. I was working at the time as a doula in Gadsden County, which for folks who may not be as familiar with the Tallahassee area, you have Tallahassee, which is pretty much a college town, a small, tight-knit community, I would say. And then you have Gadsden County, which is adjacent to Tallahassee, which is a rural community and a predominantly African-American community. In fact, it's Florida's only predominantly African-American community. So I was living in Gadsden County. I was also working as a doula in Gadsden County. And I was supporting a few birthing folks who identify as cisgender women, so I'll say mothers, who were really desiring to have a more, how should I say, patient-centered approach to their care. They wanted the home birth. They wanted to be able to have resources brought to them and birth in their community rather than driving all the way to Tallahassee. But due to several constraints, those options weren't available to them. And so I began to wonder, why don't we have these resources in Gadsden County that we have in Tallahassee? So I met with a few nonprofit leaders in Gadsden County who do a lot of work around reproductive health, including Dr. Joy Anderson, who's at Gadsden County Healthy Start Coalition. And we were having these conversations, and she was telling me about, the March of Dimes and the Maternity Care Desert map they created. And as I began to look deeper into the website, I noticed that even though we don't have these resources in Gadsden County, we were not considered a maternity care desert. So that was my first spark, I would say, in the project that said there's a disconnect here between the narrative that we see on a large scale and the narrative that we're living in community. And so I decided that I wanted to do some research around maternity care deserts, and I really wanted to center the community, which seemed to be the missing component in these larger, data infrastructures that are really funding a lot of the interventions we're trying to bring to communities, and yet they don't reflect the communities that are at the heart of these interventions. So that was the initial interest.
Would you just take a second and share with everyone maybe the definition of a maternity care desert? Just explain that, because I think that it's understood. As a matter of fact, once I got your paper and I started even to dive in myself a little bit, I added it to my doula training, because I do think it's important for everyone to understand if they're not already aware. Share a little bit about that.
Yeah, so they have 3 categories, and a maternity care desert is defined as any county, quote, without a hospital or birth center offering obstetric care and without any obstetric care provider, end quote. And that is directly from the March of Dimes website. So that would be the maternity care desert categorization. You also have limited access, which suggests that there are some providers in the community, but not necessarily the full infrastructure that you need to provide perinatal and postpartum support. And then you have full access. So Tallahassee was considered a full access county. Gadsden County was considered a limited access county. So it was painting the picture that there were more resources in Gadsden County than there actually were, because again, we had no obstetric providers at the time I was doing this project in Gadsden County providing services.
And the reason that is so challenging for families is because if you think about going to prenatal care once a month and then twice a month and then 3 times a month and then once a week, we're talking about time away from work. We're talking about transportation. For families that have transportation insecurity, that might be an issue. People that do not have funds to drive back and forth an hour each way, plus take the hours it takes to get your prenatal care. Did you find that those were some of the main factors that kept people from commuting for maternal health care?
Absolutely. Limited transportation was a huge factor in the folks I spoke to in their limitation around the kind of perinatal support they were able to achieve. There should be at least, I'm not living in Gadsden County anymore, there's the Big Bend Transit bus that supposedly takes you from Gadsden County to Tallahassee and kind of help to mitigate that gap. But a lot of the people I spoke to were not able to leverage that service. You have to call in advance. You have to get it scheduled, particularly when you're thinking of a rural community that doesn't have its own infrastructure around transportation. So you have folks at home who can't get to a bus stop, right? So that was a huge factor. There were several factors that we can talk about in terms of why this is such a huge detriment to people living in Gadsden County. But I just want to highlight that today they do have some providers coming into Gadsden County. And that was another reason why historical work is so important, because there have been periods of time within the community of Gadsden County where you have providers from Tallahassee coming into Gadsden County providing day clinics, maybe once or twice a week. And so folks were able to leverage those resources. And that is something we see today. But the interesting thing about today is that these providers who do come and provide the day clinic required that people in Gadsden County first establish care in Tallahassee. So you still have limited transportation. You still have these barriers. It doesn't necessarily solve that initial challenge that people are facing, which is getting to Tallahassee. So there's always ripple effects. There's always, I should emphasize, efforts to mitigate these gaps, but they don't necessarily address the issues because they're not necessarily talking to the people at the heart of these issues. So again, that's the overarching, I think, emphasis, and I hope it is the overarching contribution in this paper, is to really center the people who are living these inequities on the ground day to day, not only in how we are analyzing our data or treating data, but how we are approaching data in the first place and how we are approaching our interventions.
Appreciate that you mentioned the providers that are trying to do something, but we still have, like you said, the barrier of people even establishing care. And let's just say transportation isn't the main barrier. Sometimes it's intimidating to drive an hour to establish care, to just the idea of meeting, the nerves people feel when they're going to see a new provider, all of those things, and just logistically understanding how this is going to work and fit in their life. I think that a lot of times it's just easier to not receive the care at all. And, then we see more maternal health complications, and we know prenatal care is vital, to health outcomes. Let's dive into the paper. I want to hear about the research. I want to hear about how you went about gathering your information. I know you did some interviews, so let's talk about that.
Yeah, so it was a qualitative design. I wanted to do my best to do a community-based project. So one of the first things I did was establish a community advisory board. And I know a lot of us are familiar with those in the birth world. Many of us serve on them for various reasons. But the purpose of my community advisory board was to bring community members and folks within the Tallahassee and Gadsden County community who had expertise around reproductive health into one room. And by doing that, I was hoping that we could create, again, starting at the approach of the research, a design that centered the questions they wanted answers to, not necessarily questions I wanted answers to, right? So that was very pivotal. I think it shifted the focus of the project. I read the title, but the initial title of the paper was something to the effect of Gadsden County, an Invisible Maternity Care Desert. And it really emphasized like, hey, look at us. We need you too. It almost emphasized deficit, right? It almost emphasized that here is another predominantly African American community that doesn't have what it needs to thrive, which we do want to pay attention to inequities, but we don't want to label a whole community as one of deficit, or as we don't want to pathologize communities. And so the Community Advisory Board was very helpful in helping me to see what Gadsden County actually has on the ground, and really highlighting that and putting it in conversation with these larger narratives that we see around Black and Brown birthing communities. So that was part of the design. I did 44 interviews, and I should give a shout out both to my undergrad students and my Community Advisory Board. I had 4 amazing students who did 4 interviews on the project. And then I had 6 members on my community advisory board. I had Dr. Joy Anderson, who's at Gadsden County Healthy Start Coalition, Tanisha Huff, who is an incredible midwife who services both Tallahassee and Quincy, Gadsden County, Kira Adams, who is the executive director of MAPSR, Maternal and Perinatal Services, Linda Davis, who was a retired doula. She's, I think, approaching 76, but she is a wealth of knowledge. And I also had Dominica Carter, who was a mother who lived in Gadsden County, but who also worked as a counselor in the local school system in Gadsden County. So I should mention Carol Gagliano as well. She came onto the Community Advisory Board about 3 or 4 months in, and she is also a part of Healthy Start, but a different branch. And Melissa, you might understand those differences more than I do, but again, between those 6 folks, we had an incredible group of just interlocutors who helped me to really flesh out what it meant to not only center the community, but highlight what the community is doing on the ground. So I said I did 44 interviews. I spoke with mothers. I also spoke with reproductive health professionals. I was very intentional about making sure that I spoke to mothers across ages. So my youngest mother, I believe, was 68. And the oldest woman I spoke to was 82 years old, I believe. And so you can imagine the rich responses that help to trace these evolutions, if you will, of Gadsden County over time, how it has changed and how it has remained the same in unfortunate instances, across these different age groups.
I bet you could write a book just with their knowledge.
I mean, I still revisit the interviews for encouragement and inspiration. It keeps me motivated to continue to do this work.
Yeah, what a dream team, really, of just knowledge, institutional
Yes.
knowledge, of county knowledge, of experiential knowledge. Just well done. That's so exciting that you were able to have that many different voices and opinions and thoughts and experiences. Yeah, I think that's something I love. I think the most about your research is that you did really center it around the community that you were writing about, not just kind of the bigger picture, but really honing it into the feet on the ground. So
Yeah.
that's great work. So tell us a little bit about some of the things that you learned through this research and through these interviews. What were some of the key things that really stuck out to you?
Yeah, so I tried there were so many themes that I had to condense and try to tell a cohesive story. So I did that by talking about the way Black mothers and birthing folks in Gadsden County were we like to say, making a way out of no way, right? Making things work together that in reality shouldn't, but they were doing something miraculous there. So what I call that is a reproductive liberatory consciousness. And within that language, I suggest that Black mothers are disrupting these larger infrastructures that render them invisible, or they're disrupting the social order, which is something sociologists like to say, right? The way we are conditioned to see Black women and birthing people, they're saying, no, that's not me. And this is what I'm doing to ensure my survival and the survival of my children and my family, etc. Strategies that often go unnoticed in these larger data infrastructures. So I was very interested in highlighting those strategies. And the way I did that was putting it under this umbrella term of reproductive liberatory consciousness. There's a lot of work, and I won't get into the weeds of it, on Black consciousness and how people have always been moving against who they have been told they are and who they want to be, and just transforming or disrupting, again, inequities and systematic injustice. And so they were doing this as well in their maternal and reproductive lives. And so under that umbrella term of reproductive liberatory consciousness, I identified 3 pathways that highlight how women were moving through this perceived maternity care desert, right? So the first thing they were doing was they were naming barriers to care. They would be the first to tell you that Gadsden County is a maternity care desert, even though it's not accurately described as one. I had people who had very visceral responses to this language of, hey, March Dime says this community is not a maternity care desert. And they're like, how is that even possible when we don't have access to these providers, right? So they're actively aware of how their community is being miscategorized. They were also naming the cost of this miscategorization, not just as this invisible maternity care desert, but as Black women who were deserving and worthy of so many things in the patient and provider interaction that they just weren't getting, whether it's because of their race, their gender, their class, whatever. They were able to name and recognize the consequences of racial inequities and racial health disparities within the birthing moment and interaction. And we can talk about examples of that. But that was the first category, was naming barriers to care. The second one was resisting, which is really important, resisting these barriers. So not only were they saying, this is what I see around me, but this is how I'm responding to these inequities. It had several strategies. A lot of them were communal. There were probably 1 or 2 people total in my sample who did not have some type of robust form of community around them during their perinatal and postpartum journey. And no, it doesn't necessarily look like a doula, even though we love that. No, it doesn't necessarily look like a midwife, even though we love that. It looks like someone's grandmother or their aunt or their sister actively being that doula for them, actively walking through that process. And in some instances, which I try to highlight in the paper, those practices were life-saving. there were people in my sample, in my collection, who would not have survived without the check-ins and the support from their sisters and their aunts who had the wisdom and knowledge to notice signs that they needed to be mindful of. The last category, so you had naming barriers, resisting barriers, and then you had cultivating health equity. And this is where my interviews with birth workers and folks with expertise, like Melissa, thank you so much for doing an interview for the project, that really began to take shape. And one of the things you shared in your interview was just this, not only are birthing people aware of these inequities, but now we have a growing lay community who's aware of them. And the way they're choosing to respond is to actively engage in reproductive justice by becoming birth workers. And so we see a very important trend in the healthcare system and beyond of people moving in to address these inequities. And we see that in Gadsden County. I think when I was leaving, we had at least 2 people who were being trained with Gadsden County Healthy Start to come in and be doulas in that area. So we all work together, and I believe those themes work together to shift some of these inequities that we see, even as this maternity care desert language does not effectively capture not only the inequities, but how people are talking back to the inequities and pushing against that.
Thank you for having me in your interview process. It was such an honor to be involved, because this is really important work. And I feel like what I shared with you in the interview, and I think what you're speaking to, is that when I started as a doula trainer in 2009, most of the people that came through the workshop were people coming in because of their own personal birth experience, or maybe they wanted to go into midwifery school and they were kind of seeking doula work as a pathway to that. But there has been a very clear shift in the last, especially, I'm going to say 5 to 8 years. And I think there's a lot of really good reasons for that. We can go back to the ProPublica article, 2014, the New York Times article, around that same time. And then a lot of the media attention to the inequities, disparities for our Black and Brown moms, and then just in general, maternal health care numbers. Some people call it a maternal health care crisis. And I think some people go, oh, is it really a crisis? Well, we actually have the highest maternal mortality rate of any industrialized country. So I think you could say that. Yeah. But what I'm seeing now, and have been seeing the last, 5 to 8 years, I would say, and even more so the last probably 4 years, is just this real intentionality around becoming a doula. We still have people that come in that are on the pathway to midwifery school, or they had a really good experience with their birth, and so they wanted to also help others have good experiences, or maybe they had a not so good experience. They want to help others not have that same trauma they experienced. But every single training I hold, there are people in there that say, I know there's inequities, I know there's disparities, I know the maternal mortality rates are trending in the wrong direction, not in the right direction, and I want to make a difference. And that is so amazing to me that we see this. What did you call it in your third step? It was just kind of the response.
Cultivating health equity. Yes.
Yeah, I'm really glad that your research showed that, because that's definitely what I'm seeing from the doula standpoint. And we're also seeing response kind of on the bigger picture. You mentioned the Healthy Start programs. I've been working with so many of those to get their doula programs up and running. And that is going to definitely, I think, bridge the gaps that we're seeing. While the doulas aren't providing the prenatal care, so they can't help in that sense with the maternal health care deserts, they can be that voice. They can be that person, that trusted person that someone calls and says, you know what, I've been experiencing spots in my eyes and I'm having a really bad headache today. And that doula can go, we need to call your care provider. We need to make sure we connect you in to go get your blood pressure checked, things like that. Yeah, I just love this study so much that you did.
Thank you. And like you said, I'll just say really quickly, it makes such a difference, right? That one phone call, just someone to validate that what you're experiencing may or may not be normal, is huge in shifting the outcomes that we're seeing right now.
It really is huge. And I say sometimes in my doula training, we talk a little bit about how clients sometimes look to their doula, even in a clinical setting. So even in a hospital room, that maybe there's a medical suggestion that's being suggested, and they look at the doula and they go, what do you think? And as a doula, sometimes you just, feel a little like, oh goodness, because there's a lot of, expert people around and there's friends and family, but they're looking to that doula primarily because they have a trust. They've built a bond. They've built a relationship.
Yes.
And the more we have the relationship, then the better we can kind of advise them to get into care that they need to get into care. I've had clients call me post-birth, a couple days after having pretty significant complication. They call me just because we have that relationship, that trust. And I was able to get them into, see their provider, like at least encourage them. No, I think you need to make that
Right.
phone call, which made such a big difference
Mm-hmm.
because one of the things we've identified, and this actually just came across my desk, I think last week, there was a recent study that came out that was talking about how we send people home from the hospital post-birth and we say, okay, we'll see you again in 6 weeks.
Mm-hmm.
And then what happens at 2 to 3 or 4 or 5 weeks when they have something like a postpartum preeclampsia experience like you did. And if they have a C-section, we might say, okay, we'll see you back in 2 or 3 weeks, just different protocols. But there's a big gap in care in that post-care. And we know that a good portion of those maternal deaths are happening in those first 40 days. So I think that trusted relationship with doulas is just so valuable.
Absolutely, absolutely. That's some of the work I'm doing now is around postpartum support and how we really need to extend that window. I mean, we're seeing some of that happen with the changes in Medicaid and how, you have that support now for up to a year in many states. But still, it's that formal type of recommendation to come in sooner than 6 weeks, and beyond that 6 weeks hasn't really cemented yet. So I really hope to see more of that.
Yeah, I think the new recommendation I saw last week was they want people to be seen between 2 and 3 weeks. I think that's starting to come out. It takes a long time for recommendation to become practice, though. But so what had surprised you most whenever you were doing the interviews and the research? Was there anything that really surprised you?
I think a few things that surprised me that were, I'll start with the negative first, the bad news, so to speak. A few things that surprised me were the rates of infancy loss that my respondents had experienced when I was developing research questions to ask them. That was not a question. I had no question, which I look back at and think how silly. But I had no question around, have you ever experienced infancy loss? But it would just organically come up. And it was at least 2/3 of the respondents had experienced infancy loss at some point in their lives. The numbers that we were seeing were higher in Gadsden County than Tallahassee, for example, and even though my sample was small, it reflected that higher rate of infancy loss. One of the things that I guess you could say is good news in light of that, very difficult news, is many women were using their faith and their communal support to navigate the long-term impacts of such loss. There were several examples of women who did not have conversations with their family or their providers after this experience. It kind of just became like this hidden grief that they carried throughout their life. Even some of the respondents I spoke to in their 70s and 80s told me, I haven't spoken to anyone about this in decades. So to have that moment of recognition, of sitting with someone, especially as a chaplain, which I still am at heart, of sitting with someone in their grief and saying, I see you, I recognize this, and also I'm just in awe of your resilience and how you've been able to carry this for so long, was not only, I think, meaningful for me for sure, but also meaningful for them. So one of the things in a paper I'm working on now is talking about these long-term impacts of reproductive trauma. So you experience infancy loss, maybe you didn't, maybe you experience discrimination from a provider, but those things, they impact the future interactions you have with medical institutions, with faith institutions, with social networks. As we know, when you become a parent, it forever changes who you are, right? But it's also true in other dimensions of our identity. When we lose a child or when we experience obstetric violence, it forever shifts our subsequent interactions with medical institutions. So that was one of the surprising findings, was the infancy loss and just how it had a continued long-term impact on the lives of mothers. One of the more surprising, I guess, aha moments for me as a researcher, and I spoke about this a little bit, was just having respondents ask me, like, how are you really about to talk about my community in your paper? Like, don't be throwing shade at Gadsden County in your paper, which was really helpful because I think it's easy to do, to become very focused on the negative and not realize all the positive things that are going on. So just those conversations, even folks who I spoke to who would refuse to do an interview for those very reasons, but still said to me, when you do write this paper, make sure you tell the whole story, make sure you tell the whole truth. That was really helpful. And I carry that approach to research even today in my current projects.
That's wonderful. I love that so much. I'm glad that they gave you that kind of reality check too, because what a great perspective. Because we do tend to sometimes hit on the negative, I think, more than, the whole picture too, because there's probably some really amazing stories coming out just from you, like you said, the mothers and the sisters and the aunts and the people that are coming in community to try and bridge the gap themselves.
Yeah.
I mean, just that is beautiful and just really amazing and probably quite sacred. I want to talk a little bit about what you think doulas, what you think their role might be in helping bridge the gap even further in the maternity care deserts. But before we even dive into that, I want to know, if you could wave your wand, what would it look like to address this issue?
If I could wave my wand, I would encourage the March of Dimes and all the people who do large data work, which is so important, so critical. That's how we know these numbers off the top of our head, right? But I would encourage them to start again and change who's seated at the table. Because if it's only folks who have the professional expertise, right, to address these from a quantitative standpoint, then we're missing so much of the bigger picture. So we need to reorient ourselves to how we think about expertise and how we think about the timeline of any project. So I would go back and even before my research and really encourage us to include community members when at the first spark of curiosity. Before we even formulate a research question, we should be talking to mothers. We should be talking to doulas. We should be talking to midwives, because too often I think we sit in silos as researchers, and then there's the doulas and birth workers over there, and we're constantly in conversation on paper, but not in practice. So I'd really like to shift that, not only between the researchers and birth workers, but also with the birthing folks themselves, and include them because they know better than any of us.
Yeah, and it's important to have the right people at the table. Because if you don't have all the voices, I mean, you need the numbers, but you really need that personal experiential piece too. And I don't know if you're familiar with the March for Moms organization, but they actually have that same philosophy of, we're all working in silos and the same things. What if we came together? And they really wanted to center parents because they felt like parents are the ones that will probably really move the needle and make a difference. And so I think that you're onto some really good, I think, direction.
I was just going to agree with you. And there's several amazing organizations who are doing that. Like you said, March for Moms, BMMA, Feminists here in Atlanta. There's so many folks doing this work already, for sure.
Yeah, for sure. And one of the things I love about March for Moms is that they are trying to bring all of those organizations under one roof, so that we can be with BMMA, we can be with, the March for Dimes, we can be with A1, or we can talk to, the primary care physicians or the Preeclampsia Foundation, and all of those together. And we used to get to go to some of the March for Moms events in DC until the pandemic, and then they had to cancel the in-person. But they were really amazing to see all of those people together having really important conversations. And so maybe we'll see that come back. But I love that that's where your thought process goes into, how do we incorporate the community and the people who are living in this community into this conversation in a very real and tangible way. I think that's important. So if you could speak to the doula support piece of things and doulas in general, coming into the work, maybe new doulas or seasoned doulas, how do you see them fitting into making a difference or impacting bridging a gap?
I think as doulas, we have an important responsibility to be an equal advocate in this work. First, when it comes to this overarching landscape of maternity care deserts, we have a responsibility to value that information, but to also critique that information, to always kind of look at it through a lens of suspicion. What may be missing here? I know when I was working as a doula, it was valuable because it still painted Gadsden County as a limited access community. That's still valuable information. And so I think we need to be leveraging these larger data infrastructures to inform our practice. There's a lot of doulas who may be living in one community but may not be as aware of what's going on in these adjacent counties. I would just encourage you to be familiarize yourself with those efforts. There's a lot of great organizations. I think one of the biggest gifts we can give as a doula is not only collaborating with families, but also collaborating with organizations and both grassroots efforts and formal efforts that are seeking to address these inequities, not only in terms of maternity care deserts, but some of the other inequities that we see as well. I also learned, just being a part of this research, that I'm a huge fan, I should say, of evidence-based care. That goes without saying. But sometimes in that scope of thinking, I'm trying to think of how to say this in a careful way, we begin to think that that is the only way of approaching our care to mothers and birthing folks. There are a lot of practices and rituals that people would talk about in the interviews that may not be quote unquote evidence-based, but were very meaningful for the families, and I would argue potentially like a source of promoting their health and well-being. So, for example, a lot of folks talked about how their mother or their grandmother wouldn't want them to leave the house for 6 weeks after having a baby, right? We've all heard that, and it's not necessarily evidence-based care, but it became an important opportunity for folks to come to that mother or that birthing person and to put eyes on them, as they say, and just really see what's going on. And you can catch sometimes some of the physiological changes that do lead to, for example, postpartum eclampsia. We had someone in our sample who was told by her mother, do not leave this house under any circumstance. And her sister came and checked on her, I think about 2 or 3 weeks after she had given birth, and noticed she had a lot of swelling in her legs and was like, you need to go to the hospital immediately. But if she had left the house, or if she was, of course, everyone has the right to leave, but if no one was checking on her, then, who knows if that would have been something that was caught? Who knows what could have happened? So I think as doulas, we have a responsibility to not check our privilege, but check our own expertise and make sure we're not mirroring some of the ethics or postures of privilege that we might see in obstetricians, that we might see in hospital workers, right? That we're so quick to effectively critique, but sometimes it creeps up in us as well. And we have to be aware of how we're collaborating with family members, even with practices that may not be quote unquote evidence-based, but still have a lot of potential for the family.
Yeah, I love that. I think it's a really good perspective. It reminds me of one of the DONA founders, Penny Simkin, our beloved Penny Simkin, author of The Birth Partner. For those people that don't know, I think everyone listening will probably know Penny's work. But she used to say she always has a good reason. Just, sometimes people make decisions that are not, again, evidence-based, or not the decisions we would make or that we think that they should make. And Penny would say she always has a good reason. And so I think that it's really good perspective. I'm so glad you shared that. What do you think doulas can do to help build more communal relationship-centered care as they are working with clients?
I think, again, getting out into the community, being aware of what's happening in that area. And every community has a lot of heterogeneity, has a lot going on. So you have to dig deeper than just your client, right? You have to be willing to go to community events. And I'm thinking specifically of Gadsden County because I, as someone who didn't grow up in Gadsden County, I was unfamiliar with the culture there. And it's very different from, say, where I grew up in Memphis, Tennessee, right? So becoming familiar with how people gather, with how they express joy, with how they express grief, it's not the same across every group or every community. So I think one thing we can do as doulas is build, more effective pathways or relationships, not only with our patients or our clients, but with the communities they come from. Maybe that means asking the person you're supporting, what's going on this week? How can we make this visit more integrated or ingrained in the community? Maybe we are meeting at the festival that's going on, and I'm giving you insight and you're giving me insight too about what's meaningful for you and what's meaningful for your community. So we have to move beyond that one-on-one interaction model and be more interested in the multidimensional understanding of who that person is, which means understanding the community in which they're embedded in.
You're really speaking to the importance of the community-based or community-centered doula. Those that really come from the community in which they serve and how they can be impactful.
Absolutely. And I think even when we don't come from those communities, we still have a responsibility to, as much as we can. I know birth workers are super busy already on the edge of burnout, but we have a responsibility as much as we can to understand those communities, because that's where our person who we're supporting is going back to, that's going to keep them when we're gone. So yeah, community birth workers and beyond should,
Yeah.
I think, integrate
Excellent
that.
point. If there's not someone that's living and breathing within the community, then what do we need to do if we're going to serve those clients to be able to understand that community differently if it's different than our own?
Mm-hmm.
So excellent. So do you have any hopes for future research or policy shifts or around the maternity desert issue? What do you think?
I think some of the good things I've seen and have been a part of in Florida has been around telehealth. And I think it can be an important intervention in the world of addressing not only maternity care deserts, but limited access to care in general for folks across communities, both in urban areas and rural communities as well. I see telehealth bridging some gaps, not all gaps. There's some important programs with the Florida Department of Health that's bringing telehealth to a lot of communities who did not have it before, and we're seeing some really positive outcomes, at least in the state of Florida. Beyond that, I just hope that we begin to, in the research world where I see myself now, prioritize qualitative data, prioritize community voices at the same rate we prioritize large data infrastructures, which is just not the case. Numbers speak louder than people in the research world, and I hope we can see that shift a bit.
Yeah. I could see that too. So tell everybody a little bit about any last lessons that you learned or last things that you would like people to know or to know about your research or just the topic at all.
Everything has changed recently since the overturning of Roe v. Wade. So this is just a really important time for us to actually live out what this project was meant to do, which was to keep our ears to the ground. We really have to do that. We have no choice but to do that now, because we're losing so many resources, formal resources. The infrastructure that was there does not look like it did even 6 months ago. So more than ever, I hope that we are all being more intentional about creating these relationships that exist on the margins, that exist in hidden spaces, that may not look as pristine or as polished as, I don't know, our traditional pathways to care, right? But we have no choice but to really see not only what people are doing now, but there's been practices that have been sustained for decades, if not centuries, that have yet to be really highlighted in any birth working books I've read, but are very critical, especially today as we're losing access to abortion care, as we're losing access to alternative options for IVF or IUI, whatever it is, we're losing that. And so it's important for us to be mindful of what has worked prior to even having access to these things and what will continue to support us in light of these changes we see on a national scale.
Okay, so what's next for you? Tell us a little bit about your current project and what do you have coming up?
My current project actually is trying to do just that. It's looking at reproductive care and well-being in light of heightened states of reproductive surveillance. So I'm studying the reproductive lives of Black women and birthing people under moments of political instability. So what that looks like is looking across time, 3 different periods of time. I look at the period of enslavement when Black women were not just seen as producers or reproducers, but producers, and looking at maroon societies and how that functioned in the lives of mothers. I'm looking at the turn of the century when we see, of course, the rise of obstetric medicine and the decline of authority or medical authority granted to midwives and the criminalization of midwives. How were communities resisting some of these political infrastructures? And also I'm looking, of course, now I'm doing interviews with mothers and reproductive health professionals around what does it look like to experience reproductive events, not just birth, but infertility diagnoses, infancy loss, IVF treatments. What does it look like to go through these reproductive journeys in light of the political landscape we're in right now? So that's where I am. Hopefully in the next year or so, we'll have some more papers, but I'm just in the thick of it right now.
Well, you certainly did a great job on this one. And
Thank you.
I mean, it sounds silly for me to say I'm so proud of you, but I'm so proud of you. Like, it
No,
just like
thank you.
the
And
work
thanks for
is
encouraging
amazing.
me.
Yeah.
No, Thank you. I appreciate you and all you have done to encourage so many doulas, including me. When I was trying to discern whether doctoral work was for me, I remember you being one of the people encouraging me to go for it. So thank you.
Absolutely. I think that we need your voice. So we need voices like yours to be out there helping make some policy changes and helping to shape direction. I mean, even just today, you've given me some perspective that will shape, how I do things a little differently. And so that's what I'm hopeful as people listen to today's podcast, that they will maybe think about how they might interact in their own communities, even a little bit different, and maybe assess if they're somewhere in the world that has a maternity care desert that might need some different approach. Just, I think that's how we really effectively make change together, as we all look at our own individual circles and our own individual care, and we come together and we, I build community together in a whole. So,
absolutely.
Well, how can people connect with you if they wanted to connect with you? Or where could they read the paper? I'll try to link it in the show notes, but where's it published?
You can go to PubMed. I think that's PubMed.com, or you can just type in Maternity Care Desert, Rose Archer. But it's definitely on PubMed. And if you share it, I can send the paper to you if you want to put it in the notes. I can do that.
Yeah, and actually, I think I have it because I've already put it in my classroom for my doula trainees that are coming up. So yeah, it's in there. Because I think it's an important read, and I hope that they'll take that. And then listening to you today, I think explains it even in a more tangible way. So maybe I'll put this podcast episode in there and have them listen to it as well, because you had just such a lovely way to share about your experience. And how long did that research? This is the last question, I think.
Oh, no.
How long did the research take you from start to finish, would you say?
Too long, like 2 years. And it didn't get published till like year 3. Long time.
That's a labor of love, for
Absolutely.
sure. You were double hip squeezing that.
For sure.
So how can people find you?
I am on Instagram _Rose_Archer. Also on Facebook, Rosie Archer. Those are the main. Instagram is the main way, so feel free. I'd love to connect.
Okay. Well, we're going to be watching for your next paper, and I'm cheering you on.
Thank you, Melissa, and thanks for talking today.
Yeah, thanks, Rose.